Medics. Welcome to the evening webinar. Today we're going to be talking about hypercalcemia, and I think most topic is hyponatraemia. So I can see lots of you signed in. So just let us know where you're from, guys, whereabouts in the country you're joining us from, and what GP VTS you're in. We'll give you a quick shout out. We're also streaming it live on the iMedics YouTube channel. So welcome to everybody who's joining on there. And obviously, we'll be streaming there. So there'll be an opportunity if you're joining us on YouTube. There's a chat box in the corner, so you can type in there, and we'll keep an eye on those questions. So quite a lot of you have signed in. Already 47 people have signed in, which is great to see. We've got 250 sign-ups, so we will leave it running for 30 seconds or so to make sure everybody gets in. Quite a few of you now talking. So we've got Ebereri from Bedford, preparing for the AKT exam. We've got Abraham Thomas preparing for the AKT, who's from Peterborough. Welcome, guys. Natalia, sorry, didn't mean to be rude, but how long is the webinar going to be? I ordered some food for dinner. Oh my, you've actually just made us hungry by telling us that, because so it shouldn't be long. So about 40 minutes, 45 minutes, roughly. So if you're ordering food, 8 o'clock would be a good time. And I'm already now feeling a bit peckish after you mentioned that, Natalia. Jeanette from Midlands Deanery, from the Shropshire VTS. Welcome, Jeanette. Haresh Kumar is a GP ST1 in the Southwest. We've got Gagan Sethi, who's from Newport in Wales, going to join as a GP trainee from August. Welcome, Gagan. It's an exciting time. Sounds like you've probably done the MSRA exam. Yeah, it's always exciting when you start GP training. A few more people are signed in now, which is good. There was another comment. I've just disappeared off my screen. Omar from London, ST3 and Harlow VTS, sitting the AKT exam in April, which is great. So it's coming up. Fantastic. So we've got a mock AKT exam next Sunday. So we're preparing for that. So all the best for that. And that's not long to go now. So hopefully you're ready for your AKT exam. Last minute or so for us to give a quick shout out for anybody who wants to do it.
A few shout outs, VCAS, which you may have missed because you joined slightly late. So Mehmet from London, MSRA, Rabia, ST3, Pennine, Oldham, Priyana, Cambridge, sitting AKT this month, Naseem, MSRA from the UK, Theodora, AKT from Dorchester, Asma from Nottingham, sitting AKT in the East Midlands, and Farshid, Birmingham, simulated surgery. Welcome back, Farshid. Ishowi from from Leeds, ST3 AKT, Anya, Nunthorne, UK, AKT and RCA, Ebieri, Bradford, AKT, and I think you caught up from there, from Abraham, AKT. So VCAS, why don't you do a screen share if that's okay, and then we can get started.
Yeah, absolutely. So you're live on YouTube, which is great. It's a bit awkward lighting as well, isn't it, this evening? It's a bit grey outside. But here we go, guys. So can you see this, Mo? Is it full, yeah?
Yeah, nice and clear.
Perfect. So here we go, guys. So today's topic's a little bit different. So we've got a slightly different slant on the topics today. We've got more of a metabolic feel. So hypercalcemia is what we're going to talk about today, taking obviously information from the current NICE guidelines so that you're up to date, whether you're preparing for the MSRA, AKT exam, or you're sitting the RCA, or indeed you're a new GP who's about to go into practice, in which case it's relevant information for you. So as with all of my presentations, we keep it simple and to the point and with relevant information for your exams. So the objectives, remember, we define what the condition is, in this case hypercalcemia. We'll talk through some of the causes because it's quite important. There's quite lots of different causes to be mindful of. We'll talk about the key features that we tend to see, the importance about diagnosis, and of course we'll touch on the management as well. So what is hypercalcemia? Well, basically hypercalcemia, according to NICE, is a serum calcium level of 2.6 millimole, or higher than that, but it has to be on 2 occasions. Now, the cutoff of 2.6 millimole per litre will vary depending on whereabouts in the country you practice, but there's only going to be a subtle difference. So, it might be 2.8 or, 2.5 or what have you if you're in Leicester, or Newcastle or what have you, but there'll be subtle differences. But generally speaking, according to NICE, it's 2.6 millimole or more on 2 separate occasions. So what actually causes it? Now, there's a cluster of different causes. So I tried to break this slide down into the different key causes so that you've got a bit of an idea as to what could be causing the raised calcium. Remember, relevant not just for your exams, but also in day-to-day practice when you're on EMIS and you're looking through and you're going through the lab reports. Now, the commonest cause is actually primary hyperparathyroidism. Now, you probably remember this from your times at med school. Maybe if you did a surgery post, you'll be mindful of it as well. And often this is a kind of, a raised calcium in a patient who's otherwise got no symptoms. And the physiology behind it is that there's basically either too much or inappropriate secretion of the parathyroid hormone from the parathyroid glands, which of course sit in the neck. And that increased level of parathyroid hormone will interfere with the regulation of calcium in the body. So you get more bone resorption, and you get a more renal calcium reabsorption, and also you get the increased amount of calcium being absorbed from the gut, and that's an indirect effect. And normally about 85% of these cases are caused by a parathyroid adenoma with the parathyroid hyperplasia. So remember, hyperplasia is that physiological name that we have for a number of cells that start to increase very quickly within a cell, and that's the other common cause, but the most likely cause is a parathyroid adenoma. Malignancy is the second commonest cause. Now, this is very important for us to know because as GPs, we often see, if we spot someone with hypercalcemia, but they've got no other kind of features that would make us worried about any sort of immediate management needs to be done. We need to be thinking about underlying cancers. There can be a number of different cancers. And the NICE guidance actually says that that is thought to be because there's a parathyroid hormone-related protein that is secreted from the cancer, and that's what's causing this kind of calcium to rise, and it's dubbed a paraneoplastic syndrome. You may have come across this if you've been doing our question banks online, and also bony metastases. So remember, you get lots of cancers like prostate cancer, breast cancer, liver cancer, myelomas, and breast cancers and so forth that can actually metastasize to bone, causing that release of kind of calcium, and that can then of course cause hypercalcemia. Then you've got medication. Now, medication is interesting because these are some of these drugs, not all of them, but I'd say 2 of the drugs on this list we in theory do use in primary care. So the first one are thiazide diuretics. Now, they're not as common as they used to be, but if you look at your older patients, many of them are on bendroflumethiazide. That's a classic drug that was given for hypertension. We tend to give sort of chlortalidone or indapamide now. But bendroflumethiazide, you'll probably still see it on lots of your elderly patients because they've been on it for years, nobody's changed it, or it's just worked well. And they can actually cause a reduction in the amount of calcium excreted in the urine. And actually what you find is if you stop the drug, the hypercalcemia will normally be corrected. Then you've got your psychiatry drug. Now, lithium is obviously, we often see it in bipolar or mania patients. So it's a psychiatrist that will often prescribe this, but you'll probably be mindful as you're preparing for AKT that there are certain drugs that require blood test monitoring, and the psychiatrist will often write to us in their shared care management and will say, dear GP, do you mind offering the kind of treatment? Do you mind doing some of the blood tests, monitoring blood tests for this patient because he or she's been started on lithium? And we know that lithium can directly stimulate parathyroid hormone secretion, and again that causes more calcium to be reabsorbed, and therefore there's more in the circulation, and it also decreases the sensitivity of calcium kind of receptors and how sensitive they are to calcium, and therefore again can cause that kind of increased level of calcium in the blood. Vitamin D is an interesting one because we often prescribe vitamin D. So it's a hot topic, vitamin D, because lots of patients in the UK, mainly because we don't have sunlight, but of course if you've got darker skin, you absorb less sunlight, and so vitamin D deficiency is very common. And actually there's been a bit of a grey area in the sense that should you be treating it, should you not? But actually it causes a range of different symptoms like muscle aches and feeling tired and generally run down, and people often feel better with a course of vitamin D. So important thing for us to remember is that if you have excessive oral intake of vitamin D, that can also lead to hypercalcemia, as can using topical vitamin D analogues. For example, when we treat patients with psoriasis, we use things like calcipotriol, which is quite a potent vitamin D analog. So you've got to be mindful of that. Vitamin D tablets or vitamin D high strength formulations are interesting. So in our area, we practice in Coventry. We tend to give something called Invita D3, which is a capsule, and you take it once a week. It's 50,000 units once a week for 6 weeks. And that's a really high dose. So that should bring the vitamin D level up to a very high level. And after that, the patient is advised to go on to over-the-counter maintenance. So sometimes you may get patients saying, "Doctor, can I have another course?" And your response to that should be no, because vitamin D, excess vitamin D is also a factor that can actually stimulate excess calcium in the body. Vitamin A is not something that we very much give, but can be caused if you take lots of vitamin A orally for weeks or months. And obviously features of toxicity of vitamin A will include hair loss, dermatitis, and liver problems. And very rarely, if you've got sort of antacids, which are given alongside calcium and vitamin D preparations, in some cases they can cause a rise in calcium with metabolic alkalosis and impaired kidney function. So you get a kind of triad of features there on the lab findings. You've got other things to be mindful of. So now, when you see patients, this is a classic, if you like, a kind of deeper, more medical question, in the sense that, granulomatous diseases, so patients who've got sarcoidosis, that kind of shortness of breath on exertion, erythema nodosum, that's actually a feature. Hypercalcemia is a feature of sarcoidosis. It's also seen in TB, leprosy, histoplasmosis, and candidiasis. So kind of more specific infectious diseases you can actually see hypercalcemia as a feature of them. Renal causes. Now, the kidneys are very important. So we know that the kidneys play an important role in kind of regulating many of the homeostasis features of the body, as well as excreting waste products. In patients who've got chronic renal disease, they often have low calcium levels because there's hypertrophy of the parathyroid gland. Again, hypertrophy is an increase in size of the parathyroid gland, and that causes what we call secondary hyperparathyroidism, which again causes a rise in PTH and therefore leads to increased calcium in the body. You've got tertiary hyperparathyroidism, and that's when you've got these hypertrophied glands that start to produce lots of parathyroid hormone, just randomly splurting it out. And again, that causes the increased calcium absorption and calcium breakdown from the bone, and therefore it starts to rise in the body. In some patients who've got end-stage renal disease, or they've got kind of renal dialysis, they often have treatment with calcium or calcitriol or vitamin D analogues, and that can lead to hypercalcemia. Renal transplant patients, again, can sometimes get some underlying hypercalcemia, normally because they may already have parathyroid hyperplasia, which is kind of underlying underneath, and that's kind of been precipitated by this activation. They're basically giving them the vitamin D supplements and so forth afterwards. And so it's important to be mindful of that. And again, someone who's had acute kidney injury, these are the acutely unwell patients who may get kind of increased levels of parathyroid hormones just straight after acute kidney injury due to kind of a rebound response from the body. A couple of interesting features. So you've got familial conditions as well, a bit like we've got familial hypercholesterolemia. You can get this familial hypercalcemia, which is a very kind of rare, not commonly seen autosomal dominant disorder where there's an issue with calcium metabolism. There's a mutation in one of the calcium sensing receptors, and that can lead to the body being insensitive to high levels of calcium. So it's just circulating and we've got no mechanism to get rid of it. And that tends to cause mild, lifelong hypercalcemia and low phosphate. And also what you find in these patients is that actually they're normally clinically well. They don't have any symptoms. The PTH is often normal, but it can in some cases be elevated. And normally they may spot this at birth, but you can pick it up as people get older. And of course, immobile patients, so some of our elderly patients who may be kind of immobilized due to disease, whether it's hip disease, osteoarthritis, or knee arthritis, or kind of malignancy, or so forth. And also for diseases like Paget's disease, which can kind of, cause increased amount of bone turnover. Those are the kind of features which what they basically do. So if you go back to your physiology, you've got osteoblasts that build bone and osteoclasts that break it down. And what happens in some conditions like Paget's disease, you've got increased osteoclast activity and you've got reduced activity from your osteoblasts, and that causes this bone resorption. And again, that can cause an increase in the levels of calcium. So these are things to be mindful of. I mean, these are not things that will be at the top of your head, but just to be mindful. Then you've got other non-parathyroid endocrine causes. So things like hyperthyroid, like excess thyroid in the hormone in the body, will cause increased osteoclast activity, and that causes more bone resorption as well. Addison's disease is a very rare one to be mindful of, as is pheochromocytoma, and that's because there's a production of this parathyroid hormone-related peptide. And then there's obviously very rarely VIPomas of the islets, like islet cell tumors that you get, very rare, but they can also cause hypercalcemia. These are really just for your knowledge. I'll be very surprised if you got this in your exams. So what are the features? Now, you probably remember this from medical school. So hypercalcemia, remember you've got the bones, the stones, the groans, and the psychiatric overtones. So bones, in terms of patients complain of muscle aches and pain in the bones, sometimes risk of fracture in the frail elderly patients. Excess calcium can lead to the formulation of calcium-related kidney stones. So remember, you get that loin to groin pain. You may get hematuria, so be mindful of that. Groans, so that's kind of abdominal pain, so lots of generalized tummy pain. They may be constipated, they may have nausea and vomiting. And the psychiatric overtones refers to those kind of mental health symptoms like feeling low, very tired all the time and lethargic. And some patients may, in very rare cases, also go on to get psychosis. And this is why, if you look at psychiatry referrals, whether they're in primary care or in secondary care, they often want you to exclude an organic cause first. So have you done the blood test? Are the bloods normal? Yes, they are. Okay, in that case, we will take over the care of this patient. So it's one of the reasons why they do that. Diagnosis. So we talked about what we mentioned earlier on, where it varies depending on the lab that you're in, but on average, it is, more than 2.6. A mild hypercalcemia is basically when the calcium level is kind of 2.6 to 3 millimole per liter. Moderate is kind of 3.1 to 3.4, and then obviously severe is kind of more than 3.4. Now, if you're sitting in your surgery and the patient's got a 3.4, obviously you're going to call them, right? You're going to call them, you're going to find out what symptoms they've got and how they are. But severe cases need to be managed in hospital, and we'll talk about the management in a moment. In someone who's asymptomatic, or they've got a few symptoms, but they've got the mild or moderate hypercalcemia, so these two here, mild and moderate hypercalcemia, then the NICE guidance says you repeat the calcium level after 1 week to confirm that diagnosis. So remember, calcium is basically on the bone profile that we do commonly in primary care. And obviously, if the patient has still got that mild or moderate raised calcium, when you do the repeat test in a week, then you need to do one of two things. If they're clinically okay, we need to then look for other causes. So we mentioned lots of different causes, cancer being a big one. So we need to do some further tests to look for any underlying cause. And of course, if they're unwell or they're starting to get worse, or the trend shows that's going up, then we need to get them into hospital for further assessment. Management-wise, so remember, severe hyperkalemia is going to be managed in the hospital under the medical team. And normally what they do is a couple of things. They give IV fluids to kind of flush out the kidneys and really flush out any excess kind of toxins in the body. And you get IV bisphosphonates, so things like pamidronate or xylendronate are given, and they can help remove that excess calcium from the body. Remember, if it's an asymptomatic patient with minimal symptoms or mild or moderate hypercalcemia, then we can assess them in primary care. And how are we going to do that? Now, obviously, the NICE gives you lots of different lists, but from our side, what you have to do is be on the ball. So you want to take a good history, do a good systems review to make sure there's no cancer that you're missing, whether there's, maybe you want to, if it's a male, you might want to ask about symptoms of prostate cancer, colorectal cancer, lung cancer. Is there any problems with your breathing? Have you coughed up any blood? Have you lost any weight? Any changes in your bowel? These are the kind of questions that you need to be thinking about. And then, of course, if you identify them, you can, in theory, then refer them to the relevant 2-week wait cancer clinic. Otherwise, we can send them to the endocrinologist to be assessed for hyperparathyroidism. And remember, you can, if you're in doubt, you can obviously refer them to the clinic, but you can always get advice and guidance as well, where you can run through what the clinical history is, what the blood test findings are, and then the endocrinologists often give advice as to what the next step would be. So any questions? Interesting topic, a bit different to what we normally do, but we thought it was a useful one to do. I'm sure many of you are already on our social media. If you're not, Instagram, inspire_medics. There is a Facebook, AKT, RCA, and MSRA revision group. There's a YouTube channel, which we're streaming to live at the moment. My lighting is not as good as it normally is because the sky is a bit weird today. It's all grey. So I'll put my light on in a minute. And of course, Twitter as well, inspire_medics, where you can get the latest medical information. So I'm going to stop the screen share and I'm going to disappear because I'm going to turn my light on first, just so you can see me.
Okay, guys, this was Dr. Sandhu's looking for his light bulbs. And I know there's a couple of questions coming through. Just to highlight a couple of things that are upcoming. So next week we have a big AKT mock. It's Sunday, 18th of April. The price point is amazing, $99.99. Full mock, 1 hour lunch break, 6 hours of teaching. For those of you who are fasting because of Ramadan, we will be finishing before sunset. So that obviously you can open your fast. You can break your fast at the appropriate time. We've done this multiple times in the year now, and we've always got good feedback. So if you want to, if you go to our iMedics website, if you go to our iMedics Google reviews, there is feedback in the review section about the AKT mock. So you can have a read if you're not sure what the product's like. Just have a read through the reviews. And you'll see for yourself that the doctors who attended the AKT mock have written about it. So that will give you some insight into what it's like. But it's a full day. It's a full day mock, and essentially it's myself and Dr. Sandhu teaching at the end of the mock, going through the questions, giving you a breakdown of the questions, and how to obviously score the top marks with the latest NICE guidelines. We cover statistics as per the actual exam, and we also cover health administration. So quick show of hands, who here is going to be sitting the AKT this month? Just raise your hands. So in Zoom, you've got the ability to raise your hands. 4, 5, 6. So Dr. Sandhu, if you don't mind including 7 people are sitting this month. So all of you guys, if you're off on Sunday, please it's worth attending the AKT mock next week, because if you haven't got anything else to do, you're not in clinic, you're not doing out of hours, you really want to be seeing the questions. Those questions that come up in the mock that we've got prepared are not in the question bank. So they're brand new, fresh questions that have not been seen before, and therefore it's a real way of testing whether or not you're ready for the actual exam, and you will learn a lot. Certainly stuff like MEC guidelines, statistical and analysis with regards to data points, how to interpret graphs, and so on and so forth. So this quick show of hands, who here is going to be sitting the RCA exam in the next 2-3 months? So the next 2-3 months, quick show of hands, so 6 people. So for those of you sitting the RCA exam, we do have an RCA Advanced Communication Skills course. We do appreciate that some of you may have failed because the results came out in the last week or so for the RCA exam. And what we've got is a Don't Pass, Don't Pay live course for advanced communication skills that you need to demonstrate in the RCA videos. Myself and Dr. Sandhu cover 10 high yield areas. There's a 1 hour lunch break, and if you fail, you do get your money back. So very low risk, and it's on the 6th of June 2021 if you're resitting. Similarly, we've got RCA mocks if you feel like you want to practice RCA video consultations with a GP and get some feedback at the same time as to where you may need to improve. Booking for the RCA mocks, only $54.99. Dr. Sandhu is going to include the links. Now, those mocks are very different to the coaching. So the coaching is very intensive. Essentially, in the coaching, we stop you at the points at which you're making the mistakes. We teach you how to correct, and then we move on. Whereas in the mocks, we just role play the cases, and then we give you 2 minutes of feedback at the end. So coaching is much, much more intense, which is why the price point is a lot higher. So if you feel like you're someone whose score for the RCA exam was very, very low, please book in for the coaching, because that's what you need. You need someone to analyze your consultation style, break it apart, rebuild it, and then from there, you can score the top marks. You can choose 2 or 3 hours, but if you feel like you just need a bit of brushing up, a bit of feedback, and you want a bit of practice, it's the RCA mocks that you want to go for. For those of you who feel like you are visual learners, we have the RCA gold standard consultation videos. These videos are basically videos done by myself, role playing with actors, and where we break down cases. So there's different cases, for example, menorrhagia, pregnancy, domestic violence, STI, and I demonstrate to you how you would consult to score the top marks. But within the video, we actually give you a subtitle feedback to talk you through the different domains. So interpersonal skills, data gathering, management, what's happening within the consultation to score the top marks. And again, there's different packages, so have a look when you get a chance. Bronze, silver, gold. Gold is the most popular package that most GP trainees go for, because it contains 170 videos, over 20 hours of HD video content, 59 core cases with examiners mark sheets. So these are RCA examiners mark sheets. And you can learn a lot simply by just going through these videos and the examiners cases that we've included. What else do we have? Okay, we have another video course. So this is an online video course. I won't touch on that, but essentially we've also got blogs. We'll come to this at the end of the day as well. So for those of you who want to read a bit more information around the MRC GP exams, we've got blogs which Dr. Sandhu will include as a link, and you can read various different articles depending on where you are in your career. So for this one, for example, endometriosis, oral hygiene, breaking bad news is a very, very comprehensive article. And then we've got, for those of you sitting the RCA exam, how do you explain conditions within 10 seconds? These are 60-second patient leaflets. If you read about them, you'll know how to explain a condition, its management, its prognosis in a very short span of time. We've made it very, very easy to digest. So let's choose, for example, thrush as a case. I'll let that open. And then finally, we also have a forum section on our website. If you want to discuss between deaneries, between doctors, different topics, you can post your questions into our forum area, which is available via the mega menu bar at the top of your mobile device. There's a burger bar menu. Click on it. At the bottom, it says forums. Click on it. Log in with your iMedics account. I think most of you are on our AKT free question bank. Please let your friends know. And then you can choose the relevant topic area to post your question. So for example, thrush, vaginal thrush, we've got causes here. What are the symptoms? How do you diagnose? How do you treat? And why you should worry. So very, very useful bits of information, which will allow you to basically read that information and then relay it back to a patient. So just going to stop the screen share there because Dr. Sandhu's got a few questions that he needs to answer.
Perfect. Thank you very much. So just see where they've gone. So where are we? I think it's got lost in there somewhere. Here we go. So question from Omar said, do we always have to check calcium levels after the vitamin D has been replaced? And the answer to that question is no, you don't. So as long as you follow the guidance, which does vary, by the way, depending on your area. But in our area in Coventry, we tend to have, we've got two options, but one of them is Invita D3, which is a 50,000 unit a liquid capsule, and the patient has to take it once every week for 6 weeks. And then good practice, so I tend to write this on the prescription, which is take one capsule once a week for 6 weeks, then start over-the-counter maintenance. And obviously, as you guys know on EMIS, once you've written it, it automatically saves it. So you don't then have to check it as long as they don't develop any symptoms, and you don't then go on to give them a second dose. And this is why you have to be very careful with the EPS stuff. So when you're signing prescriptions, obviously now we do it electronically, sometimes you may get a request from a patient, oh, I need some more vitamin D high dose, and you should be thinking, well, actually, let me just check the notes and see how long this patient has had the vitamin D for. So that's the side of it. Now, Abraham has said, nice, says 2 weeks after commencing a high dose. Again, very variable. So it depends on whether the patient's got symptoms, because ultimately you'd be, in theory, checking the calcium on everybody. So in theory, I'd probably say no to that, but we'll double check that for you anyway. So you're suggesting that 2 weeks after you've done a high dose, you should go on to check the bone profile. So we will double check that. We've got another question from Mary. Do we order scans for parathyroid, or can it be done from secondary care? So either or, really. So in theory, you could organise the scan while you're waiting for the referral. That's good practice, rather than kind of, because if the calcium is persistently high, in theory, you're going to have to refer them to endocrinology if they're otherwise well. But you can certainly request it while you're waiting. We've got a question from Archana. Do we need to add calcium and vitamin D when we start patients on bisphosphonates for osteoporosis? Again, very good question. So this is often something which we do see. So a lot of our elderly patients get put on bisphosphonates, and often we do put them on, but the dose of the calcium and the vitamin D that we give is not going to be the high strength treatment dose unless they've got a vitamin D deficiency, which often they won't have. So we will put them on a standard dose, a maintenance dose in the background, rather than going for an aggressive dose.
Yeah, and that, just to add to that, Vikas, the bisphosphonates, if you start a patient on bisphosphonates for osteoporosis, the calcium depends on whether or not the patient's got enough calcium in their diets. So if they don't have, and you feel like they don't, then you can add it in. And the vitamin D helps the mineralization of the calcium, which is why it's provided as a combination.
Yeah, fair enough, yeah.
And then I think there's just one last question, which is, can the AKT mock be purchased for viewing on demand? And unfortunately not, because we try and keep it as an interactive session where possible later on in the day. So it's a live mock. Obviously the questions show up 1 minute at a time. And then after the lunch break, we go through the questions, but we answer questions at the same time. So it's very interactive, and we don't live stream, unfortunately. But if you've got time, if you've got the opportunity, do attend the live mock. So if there's no more questions for the hypercalcemia topic, I think what we can do then is move on to the next topic area, which is hyponatremia, which is obviously a low sodium level. So I was supposed to go first actually for this presentation, which is why the order is slightly wrong here. But essentially, we're going to go through the latest guidelines for hyponatremia, and then we'll do a Q&A afterwards. So let's do a quick recap first. So for those of you who have attended these iMedics webinars, you know that me and Dr. Sand have got slightly different styles. I like to highlight 3 key pieces of information, maybe 4, which are going to be most relevant for your MSRA, RCA, AKT exams. Essentially what's most likely to come up and what's going to be most useful for you in day-to-day practice. And the reason I tend to do that is because I don't want to overload you with information. You can go away, read about hyponatremia for an hour, for example, but you need to basically pull out the information which is going to be the most useful. And all of you have got different learning styles. So some of you are visual learners, some of you like to read, some of you like to listen to our podcasts. So we've got podcasts where you can listen about hyponatremia, and those are nice guidelines. But let's do a recap to begin with. Let's get your knowledge back up to where it should be at the baseline, i.e. from medical school, and then we'll go on to the nice guidelines. So what's hyponatremia? Obviously, it's a low sodium concentration, but specifically it's less than 135 millimoles per liter. So serum concentrations are concentrations within the blood, and you can break it down into the classification that NICE use is mild, moderate, severe. They also have a acute onset and a chronic classification, but we won't touch on that today. That's a different type of classification that they have. So mild essentially is between 130 and 135 millimoles per liter. Moderate is a sodium concentration of between 125 and 129 millimoles per liter, and severe is if the sodium concentration is less than 125 millimoles per liter. Now, a lot of you are not going to remember this the moment this webinar closes, and you're gonna be like, okay, what was mild, what was moderate, what was severe? And probably the best way to remember it is it's going to be rule of 5s. So I always remember a normal parameter or normal range for sodium is 135 to 145. That's something I've just memorized from the top of my head. But in terms of the actual subcategorization of mild, moderate, severe, I go by rules of 5. So from 135 to 130, that's mild. So 129 to 125, which is a little bit weird because it should be 130 to 125. 129 to 125, it's a moderate, and anything under 125 is severe. So quite quickly, when I'm looking at blood test results in EMIS or in the PATH lab results, I can see what's mild, moderate, and severe. So moving on to the next slide. We need to give you a bit of background in terms of how sodium levels are moderated or modulated within the actual blood. So there is, and this is again recap, there is a hormone that gets produced by the hypothalamus called ADH, The other name for ADH is vasopressin, and vasopressin basically acts on the kidneys, and when increased levels of ADH are released, the kidneys reabsorb more water. So ADH stands for antidiuretic hormone, i.e. it stops you from peeing out, essentially. And why is hyponatremia such an important topic? So some of you may have seen this clinically in real life, and it's very rare, but very sudden changes in sodium levels or severe abnormalities in sodium levels can result in cerebral edema. Basically, fluid builds up around the brain, and that can be a potentially life-threatening problem, because it can lead to headaches, vomiting, seizures, coma, and eventually death. And so that's why it's so important to pick up on early, especially if there's a trend where you're dropping your sodium levels on a consistent basis. Now, the other way, now this is very useful. So let's talk about some learning points. What are the causes of hyponatremia? Certainly as a hospital doctor or a GP or a trainee, you want to be thinking in your mind, what are the causes of the low sodium? And there is one way of thinking about low sodium in terms of volume, of fluids within the body. So NICE has 3 types of stratifications for this: hypotonic hyponatremia, hypovolemic hyponatremia, and euvolemic hyponatremia. So let's expand on those a bit more in further detail. So hypotonic hyponatremia basically is when the body's lost fluid, but it's also lost sodium at the same time, which means that the sodium concentration has dropped. And if the body's losing fluid, obvious examples are going to be things like diarrhea, vomiting, and use of diuretic medications. But other conditions which can cause a hypotonic hyponatremia is Addison's. Don't forget, with Addison's, you get hyponatremia, but you also get hypercalemia. Secondly, we have hypovolemic hyponatremia. This is where there's more fluid in the body than there should be. So any situation in which there's edema in the body, heart failure, kidney failure, renal failure. And so you want to be thinking about volume overload situations, and that can potentially lead to hypovolemic hyponatremia. Then you have this really interesting euvolemic hyponatremia, which most people think, oh, nothing's changed, but that's not quite true. In euvolemic hyponatremia, the volume of the fluid, essentially water within the body, increases, but the concentration of sodium does not catch up with it. And so volume increases, sodium remains the same, and as a result, you get a low concentration of sodium in the blood, and that's euvolemic hyponatremia. That commonly occurs with patients who are using or taking SSRIs, or have a syndrome of inappropriate diuretic hormone release as a condition. And that's how you would classify various different hyponatremias. Now, today, what we're going to do, we're going to focus in on the drug causes, because this is an area that very commonly gets tested in the AKT exam, but also in the MSRA exam, and it may be something that you come across in a RCA type setting. So the common drugs, so these are the common drugs which can commonly cause hyponatremia, are diuretics, SSRIs, antipsychotics, and carbamazepines. Don't forget, diuretics can be any type of diuretic. Specific, so in terms of the family of diuretics, thiazides are more common in causing hyponatremia as opposed to loop diuretics. But antipsychotics and examples of antipsychotics can be haloperidol and phenothiazines. These are the common drugs which can cause hyponatremia. And don't forget, hyponatremia is commonly found in elderly people. If you talk statistically, epidemiologically. So when you start getting hyponatremia in a younger individual, then you're probably thinking about more organic causes: diarrhea, Addison's, possibly renal failure, or SIADH. But the general causes for hyponatremia tend to occur in older people. In terms of drug causes which can cause hyponatremia and are less common, these are the drugs which can less commonly cause hyponatremia. Now, I've specifically color-coded these because I want you to pay attention. I want you to pay attention to this slide because the color coding represents different mechanisms of hyponatremia. So for the blue ones, opioids, ACE inhibitors, ARBs, proton pump inhibitors, anticonvulsants, amiodarone, theophylline, dopamine antagonists, antidiabetics like insulin and tolbutamine, NSAIDs, and MDMA, which of course is ecstasy, fall under one type of hyponatremia effect. NSAIDs fall under a different type of hyponatremic effect, and then desmopressin and oxytocin fall under a different hyponatremic effect. So would anybody like to guess from the audience, from the participants, what mechanism of action the blue drugs are having, which results in hyponatremia? Anybody like to type into the chat box what the blue drugs might be, what the mechanism might be for causing hyponatremia? So fluid retention, hypovolemic hyponatremia. Good. How about the NSAIDs? What pathophysiology is occurring to cause hyponatremia for the NSAIDs? Euvolemic dolapo, and then finally desmopressin and oxytocin. Anybody like to take a guess what pathophysiology is occurring with desmopressin and oxytocin, which results in it causing hyponatremia? Euvolemic. Okay, folks, yeah. So let's move on to the reason. So with the blue drugs, those specific drugs can increase the production of ADH or potentiate the effect of the existing ADH. So it's just important, it's just good to know for pathophysiology purposes. For the NSAIDs, they actually cause a loss of ADH inhibition, so the body doesn't react as well to the ADH in the first place, a type of siADH. And then finally, exogenous ADH, so actually putting in ADH into the body, can cause hyponatremia. And you can, of course, get desmopressin and oxytocin as drugs, which can be given to patients. So, and you are right, some of you are right in terms of the euvolemic, and that does, of course, is a type of classification for some of the drugs causing hyponatremia. Okay, let's move on to the third key learning point for today. How do you manage hypovolemia? Now, in order to manage hypovolemia, you must first of all classify it, which we've talked about, mild, moderate, severe. And then the NICE guidelines are very clear on how you manage it. If the hypovolemia is severe, i.e. under 125 millimoles per liter, you must admit the patient immediately. So that there's a risk of a coma, risk of death. The patient needs to go into hospital, further investigations, find out the cause, correct the abnormality safely, because remember, wild swings in sodium levels, serum sodium levels, can result in cerebral edema. If the patient has, and this is really interesting, NICE actually recommend that in a community setting, if a patient has moderate hyponatremia, so between 125 to 130, you should discuss it with the endocrinology team. And that's assuming the patient's asymptomatic. They have not elaborated on what to do if the patient's symptomatic with moderate symptoms. So I'm assuming if the patient's symptomatic with moderate symptoms, you would probably discuss it with the endocrinology team, and you're potentially looking to admit the patient for further investigations within a secondary care setting. But the guidelines are very clear. Moderate hyponatremia, you discuss with endocrinology for any further advice or management that they may recommend. Now, with regards to mild hyponatremia, that can be generally managed within the community. So what you want to do is repeat their sodium levels, usually within 2 weeks, but sooner if possible, if you're suspecting the sodium levels are dropping consistently. And of course, you want to stop any medication associated with the low levels, which might be contributing to the hyponatremia in the first place. And we have covered a lot of those. So a lot of these are common drugs. Patients will be taking codeine, for example, omeprazole, ramipril. Then you have thiazide diuretics. Citalopram is the most common SSRI to be associated with hyponatremia. So again, these are relatively common drugs we prescribe as GPs and hospital doctors on a day-to-day basis. So just by stopping these meds, repeating the serum sodium allows us to determine whether or not there was any causation effect between the two. So what we're going to do, just going to pause it there to take any questions. I'm going to give it 2 or 3 minutes. There's a lot of background noise. It should be fixed now, hopefully. Vikas, was there a lot of background noise going on?
There was, yes. I think your dinner's being prepared, Dr. Mo.
Okay, so apologies on my side, guys. It's going to stop the screen share there for a moment in case you guys have got any questions.
So just while you do that, Dr. So I'm going to give, so actually a couple of good points. So Abraham raised a good point about vitamin D. So I had a little look while you were doing, and I pasted it in. So a very valid point. So basically I pasted in what the NICE guidance says, which is that within a 1 month of completing high dose vitamin D treatment, you should check the calcium levels, but you can consider checking it more regularly, like every 1 or 2 weeks within the first month of treatment, if people are getting calcium supplements in addition to the high dose vitamin D treatment. So I hope that makes sense. And Abraham, well spotted there. So, and that's because, as you rightly said, it may unmask underlying hyperparathyroidism. Quick question for you, Mo. Do you do that regularly after vitamin D? After you've given high dose vitamin D, do you check calcium frequently?
The short answer's I hardly ever check it. I mean, I know the guidelines mention PTH and calcium levels usually at the end of the completion of the course. I very rarely do it, because most of the time what I found was either the PTH is normal or the calcium is normal and you don't do anything, or the PTH is raised or the calcium slightly raised, but the patient's asymptomatic and you recheck it and it goes back to normal. I think the guidelines are guidelines, guys. I mean, I know they're best practice, but certainly if the patient was symptomatic, so if they were, for example, developing abdominal pain, change in their mood, if they were finding that they were constipated, then I'll be thinking, yes, I need to check the calcium levels because they may be abnormal. But in an asymptomatic patient who's perhaps got a slightly raised calcium, there's no real justification there. But it depends. Obviously, as clinicians, you get more and more experienced, and you'll rely less on guidelines and more on intuition. But guidelines are good because they give you a reference point on which to act. So I hope that answers the question.
Yeah, no, absolutely. That's a good question. So they didn't mention PTH, actually. It's just calcium, because parathyroid hormone is quite an expensive test. And from what I remember, does it go on ice?
What, PTH?
Yeah.
I don't think it does from the top of my head. Because remember, guys, PTH levels correlate with calcium levels, because PTH levels affect serum calcium levels. So
yeah, you're right. That's a good point. So because you wouldn't, I mean, NICE doesn't mention that anyway. So it's mainly whether you should do a bone profile. Now, I must admit, it's not something which we commonly do, which is interesting. But it's an interesting point to be mindful of. Lisa asked about lithium as well. So so I had a quick look, I gandered into the NICE guidance to see what's going on with lithium. But lithium is basically a couple of bonus points, but obviously you measure it 12 hours post-dose. But the psychiatrists normally say it's the BMI, Usinese, eGFR, and the calcium and the thyroid function every 6 months. But you do it more often if they've got evidence of kidney disease.
Okay, a few other questions, guys. From Mary, how can you stop SSRIs abruptly if the sodium's low as risk of discontinuation syndrome? Very good question, Mary. In mild to moderate, you would probably reduce the dose. So you may drop the dose from 40 milligrams to 20 milligrams and then review in 2 weeks' time with the sodium levels. If it's an acute emergency situation like a dangerously low sodium level, then certainly you're probably going to have to stop it as per the benefits versus risks. So I hope that answers the question. A few other questions coming through. I don't know, Omar, if you can clarify your question about osmolality. Maybe it's for Dr. Sandhu. Fozia, what if the repeat test also comes up as mild hyponatraemia? Patient is not on any medication, which might be causing. You want to screen for other organic conditions which might be causing it. So has the patient potentially got heart failure? Are they developing liver failure? Have they had diarrhea and vomiting over the last few days? Is there an organic cause which might be resulting in low sodium levels? Is the patient possibly got Addison? So again, this is where your history taking comes into place. So your history taking should allow you to work out where the mild hyponatremia is occurring. If it's persistent and it's ongoing and there's no obvious cause, then you may need to get advice and guidance from the endocrinology team. Asma, so Vikas, that's for you actually.
Yeah, so Asma's question was with moderate levels of hypercalcemia and an asymptomatic patient, would they most likely be, which you think is most likely due to medication? Would you still recommend calling an endocrinologist or just stop the medication and recheck? So good practice would be to stop the medications. If you think it's bendroflumethiazide, stop it, recheck, and then if it, and as I mentioned before, what the current guidelines do say is that actually, if it is a drug that's causing the hypercalcemia, if you stop it, it will normally resolve. Obviously, if it carries on persisting, then we would get the endocrinologists involved. I think we've had some clarification. So I think the urine osmolality is actually related to hyponatremia. It's not a test, and Omar's clarified. So do you check urine sodium levels and plasma levels in the event of low sodium? So that's a good question. So that's one for you, Mo. But certainly, generally speaking, I don't think I've ever tested a urine osmolality. And I don't know, again, Mo, if you have, or whether, it's something that you commonly do. I mean, I have seen very, very mild hyponatremias in primary care, like, a level of 132 or 133. But normally that resolves. But I've not seen I don't think I've ever done one. I don't know what your thoughts on that.
No, you wouldn't commonly check it in primary care. In secondary care, you would check it because you then start thinking about other conditions, endocrinology type conditions, which might be causing the hyponatremia. So no, certainly not, hardly ever in primary care, but yes, in secondary care for certain reasons on the instructions of an endocrinologist or the endocrinology team or the acute medical team, for example. Guys, I've just left a Google link in the chat box. If you click on it, or if you Google iMedics, we'd really appreciate if you could leave us a 20-second review on Google. If you found today's webinar useful, or if you found our AKT/MSRA free question banks useful, which we spent like 3 years building, please leave us a nice Google review. This helps us get out there to other registrars and doctors who are struggling with revision, who obviously have got lots of costs going out and they want to find a free question bank. That's how they find it. Google then optimizes us for free question banks. And then Lisa, thanks for the comments. Fozia, you as well. And then other registrars and doctors and junior doctors can find the website a bit easier. So I'll quickly show you how it's done. So basically all you need to do is go to Google, type in iSpace Medics on the right-hand side, or on your phone devices at the bottom, there's a Google reviews. If you click on it, there's a blue button, write a review, and then you can leave us a review. Would really appreciate it, me and Dr. Sandhu. It takes literally 20 seconds. And then don't forget our AKT Big Mock next week. So take your time, book in this evening. You've got 7 days, and we'll send you a Zoom link. And then if you have failed your RCA exam, please do check out the mocks, the coaching, the gold standard consultation videos. And for those of you who like reading, we've got plenty of blogs on our website and the forum section if you want support from other doctors in the country. So Vikas, anything else you want to add there?
No, thank you very much, guys, obviously for joining us. So we'll be ready with the next webinar in the next few weeks. Just let us know if there's any topics that you want us to go through. Some nice comments coming through from everybody. We appreciate that, obviously. Lisa, thank you, our medics team. Haresh, thank you both. Much appreciated. Tamanna, thank you both. Ania, thank you. iMedics. Abraham, thank you, guys. Good discussion. Thank you, Abraham. Very well contributed there with some good learning for everybody, which is what we like, by the way. Keep it interactive, guys, because everybody should learn from each other. Hamateyu, thank you very much. Nasreen, thank you very much. Gagan, thank you, very useful session. Ifi, thank you both. Theodore, thank you. Javaria, thank you both. Thank you very much, guys. Archana, thank you so much for all you're doing. Such a good job, really useful. Thank you, Archana. Thank you. Arnel, great presentation. Priyana said thank you, and Fawzia said thank you, good review. Thank you, Fawzia, if you left us a Google review, we appreciate that. Guys, we will, Fiona's also said thank you both, so we appreciate that. So I know it's a Saturday night, I know that some of you, I think Natalia's dinner's ready, I think my tummy's rumbling a little bit as well. I'm sure you'll want to kind of enjoy the rest of your Saturday evening. So thank you for joining us. Let us know if you've got any topics that you want to do, just reach out to us on our social media channels or drop us an email. We'll be back with some more webinars, and obviously, as we always say, keep safe at this difficult time. Hopefully some of you are getting a second vaccine. So it's a good evening from me, and we'll see you very soon, and I'll hand over to Dr. Mo for any closing comments.
Yeah, thank you, guys. Farshi, if you type into Google iMedics, iSpace Medics, and then if you scroll down, it'll say Google reviews for iMedics. If you click on it, then you can leave a review. But thank you guys for joining us. The next free webinar is in a month's time, because there's a gap now. There's a summer gap for the AKT, RCA, MSRA exams. Lots of luck with the exams that you are sitting. Hopefully you've learned lots today. Please let your friends and colleagues know we've got a free question bank. We don't spend any money on advertising anymore because obviously it costs a lot, unlike some of the other bigger organizations out there. And of course, stay safe during the COVID pandemic. So we see